Hello everybody. Today I will talk about pathophysiology of the cardiovascular system, heart failure. Today we will consider circulatory failure, definition classification, heart failure definition classification, etiological factor of heart failure, pathogenesis of acute heart failure, the pathogenesis of chronic heart failure, compensation mechanism for heart failure. Morbidity and mortality rates from cardiovascular disease still rank first among the causes of disability and death. It is known that the so-called factors predispose to the onset of disease of the cardiovascular system. The main factors determine the high incidence of cardiovascular pathology. Repeated prolonged stress with emotionally negative coloration leading to the development hypocapnia, chronic physical inactivity, alcohol intoxication, systematic smoking of tobacco, excessive consumption of tea, coffee, and other household doping, poor quality, imbalanced nutrition, and overeating, overweight, and etc. Normally, the cardiovascular system optimally provides the current needs of organs and tissues for blood supply. Adequate blood circulation depends on the activity of the heart, vascular tone, volume of circulating blood, rheological properties of blood. Therefore, violations of the functions of the heart, vascular tone, or quality and quantity of blood can lead to circulatory failure. Next point of lecture plan, circulatory failure, definition and classification. Circulatory failure is a condition of a cardiovascular system in which the organs, tissues, and cells of the body are not provided with sufficient blood supply. In other words, circulatory failure is a pathological condition in which a cardiovascular system does not provide organs and tissues with necessary amount of blood adequate of their level of functioning with normal or increased venous return. Next slide, the main cause of circulatory failure. Cardiac disorders, of the tone of the walls of blood vessels, change in the volume of circulation blood, and or rheological properties of blood, distinguish between a cardiac form of circulatory insufficiency, a vascular form, and a combined cardiovascular form of circulatory insufficiency. Heart failure definition classification. Heart failure is a condition in which the heart as a pump does not provide the metabolic needs or organs and tissues with the required amount of blood. In other words, heart failure is a typical form of cardiac pathology in which the load on heart axis is ability to meet the needs of the body. Heart failure is a syndrome caused by decompensated myocardial dysfunction. It is manifested by an increase in the volume of intercellular fluid and decrease in organs of tissue perfusion. The pathophysiological basis of this syndrome is this heart cannot provide the metabolic needs of body due to violation of the pumping functions or does this increase the end diastolic pressure in the ventricles? That is the minute volume of blood flow decrease and generalized circulatory hypoxia develops. The main pathophysiological criteria for heart failure include decrease in minute volume of blood flow, inadequacy of tissue needs, development of generalized circulatory hypoxia. Next point of lecture plan, etiological factors of heart failure. Etiology of heart failure. Causes that have a direct damaging effects of the heart. Reasons leading to functional overloads of the heart. Reasons reduce the contractile function of the heart. Next slide. Causes that have a direct damaging effects of the heart. Physical nature, compression of the heart, exudate blood, tumors, etc. Electric current in case of electrical injury, heart defibrillation, mechanical injury, chest contusion, penetration wounds, surgical procedures. Causes that have a direct damaging effects of the heart. Chemical nature, non-medical chemicals, compounds, enzyme inhibitors, heavy metal salts, drugs in an inadequate doses, such as calcium antagonists, cardiac glucosides, oxygen deficiency, lack of chemical compounds necessary for metabolism, metal salts. Causes that have a direct damaging effect of the heart. Biological nature, high content of biological active substance, deficiency or absence of biologically important compounds necessary to ensure metabolism, such as enzymes, vitamins, substrates, prolonged ischemia of myocardial infarction, cardiomyopathy. Reasons leading to functional overload of the heart. Factors leading to functional overload of the heart muscles include increased preload, this is volume overload of the diastolic phase. It is not for heart defects such as aortic valve insufficiency, mitral valve insufficiency, hypervolemia. Increased afterload, this is pressure overload in the systole phase, increased resistance to blood flow. It is also known with heart defects such as stenosis, hypertension, and the pulmonary circulation. Lesion of the systemic circulation, arterial hypertension, and increase in the total peripheral vascular resistance. Reasons that reduce the contractile function of the heart. Segmental dysfunction, this is includes myocardial infarction. Global dysfunction includes myocardial diseases. Next slide, next point, classification. The following types of heart failure are a distinguished classification by the rate of development flow: acute, minutes, hours; chronic, weeks, months, years. For the predominantly affects part of heart by localization, left ventricular, right ventricular heart failure, and total. According to the primacy of violation of the contractile function of the myocardium or decrease in venous return of blood to it, primary cardiogenic, secondary non-cardiogenic. Primary cardiogenic as a result of decrease of contractile function of the myocardium with normal venous return. Secondary non-cardiogenic as a result of decrease in venous blood return. Minute volume of blood flow decrease due to a fall of the circulatory blood volume, hypovolemia, shock, portal vein thrombosis. Acute heart failure develops over a short period of time, minutes, hours, occurs when acute myocardial infarction, multiply pulmonary embolism, hypertensive crisis, acute toxic myocarditis. Chronic heart failure develops for a longer time, weeks, months, years. It is adequate blood flow is ensured by compensatory mechanisms that cause cardiac hyperfunction. Occurs when chronic arterial hypertension, chronic respiratory failure, long-term anemia, chronic heart defects. Next point, pathogenic aspects of heart failure. Let's consider the links of pathogenesis in hemodynamic variants of heart failure and links of pathogenesis for typical lesion of the heart. Systolic dysfunction is a decrease in the contractility of the left of right ventricle with a decrease in cardiac output. This is an option with increased afterload. In other words, pressure overload is the systole phase. Pathogenesis. As a result of decrease in myocardial contractility, cardiac output decreases, hyperfusions of organs develops, especially the brain, heart, kidney, and muscles. Sympathoadrenal system is activated. Vasoconstriction occurs in the periphery. The total peripheral vascular resistance increase, and then afterload of the heart increases. Renal ischemia leads to the increase in the amount and activity of renin and angiotensin 2, an increase in the concentration of aldosterone, vasopressin, as a result of which sodium and water retention occurs. Plasma volume increases, the preload of the heart increases, and edema develops. In muscles, accumulate lactate, develops atrophy, fatigue. Main clinical criteria for systolic dysfunction. First, decrease in ejection fraction, less than 50%. Ejection fraction equally the ratio of stroke volume of the heart to the end diastolic volume, multiplied to 100%, normally more than 16%. Increase the end diastolic volume of the ventricle. Diastolic dysfunction is a decrease in relaxation, extensibility, and left-right ventricular filling. This is an option with increased preload of volume overload in the diastolic phase. Pathogenesis. Decreased compliance and the impaired filling of the ventricle lead to an increase in it is of course diastolic pressure, which cause decrease in cardiac output, the pressure in the corresponding atrium, blood circulation increased, and it increased even more load on the myocardium, accelerates the progress of heart failure. Main clinical criteria for diastolic dysfunction: decrease in the volume of blood entering the ventricle in the face, quick filling; increased volume of blood entering the ventricle during atrial systole; the ratio of the volumes of blood entering the ventricle during the phase of rapid filling, slow filling, and atrial systole is normal. Ratio E to B to A 60 to 20 to 20%. Quick filling to atrial systole more than 2. For diastolic dysfunction, ratio E to B to A 30 to 15 to 55%. Ratio quick filling to atrial systole less than 1. Ejection fraction and diastolic volume are normal. Left ventricular heart failure occurs much more often than right ventricular. Despite the fact that the left ventricle of the heart is more adapted to increased load, this is due to fact that various pathological condition often leads to overload of the left ventricle. Acute left ventricular heart failure occurs when arterial hypertension, hypertensive crisis, myocardial infarction, reversible left ventricular ischemia, avulsion of the papillary muscles with mitral valves prolapse. Chronic left ventricular heart failure is slowly developing pathological condition that complicates of cause of chronic diseases of the heart and blood vessels. Pathogenesis of acute left ventricular failure is the result of the action of the etiological factor. The contractility of the myocardium of the left ventricle decreases, and that of the right remains. The pressure of the left atrium increases. The hydrostatic and hydrodynamic pressure in the arteries and pulmonary circulation. The hydrostatic pressure in the pulmonary papillaries increase. The increased pressure in the left atrium triggers the Kitaev reflex, which is based on spasm of the arteries of the pulmonary arterial system, is responses to high pressure of the left atrium. This further in the interstitium surrounding the pulmonary arterioles and capillaries. Edema of the artery of the alveolar capillary membrane occurs. Diffusion of gases becomes difficult. Cardiac asthma. Due to ongoing sweating, the liquid parts of the blood enters the lumen of the pulmonary alveoli with the development cardiogenic pulmonary edema. The sweating liquid contains red blood cells and a lot of proteins, which is formed by the flow or air of in the alveoli and bronchioles with the formation of pink frothy sputum. Progressive difficulty is diffusion of gases leads to hypoxia, hypercapnia, At first respiratory and then mixed acidosis with the development of the entire clinical pictures of pulmonary edema. Acute left ventricular failure is clinically manifested by cardiac asthma, pulmonary edema, and cardiogenic shock. Right ventricular heart failure, characterized by development in congestion in the systemic circulation, is accompanied by increase in the resistance of the vessels of the pulmonary circulation, which leads to an increase in the volume of blood flowing to the right ventricle and to its overload. Acute right ventricular heart failure occurs when spread of large focal left ventricular infarction to right heart isolated myocardial necrosis of the right ventricle, less common acute pulmonary hypertension, pulmonary embolism with the formation of infarction, pneumonia. Chronic right ventricular heart failure formed is chronic obstructive pulmonary disease, bronchiolitis, bronchial asthma, pneumosclerosis, pulmonary emphysema. Pathogenesis of acute right ventricular failure. Etiological factor leads to an increase in pressure in the pulmonary circulation. A rapid development of pulmonary hypertension occurs, followed by a high load on the right ventricle. A decrease in blood flow to the left ventricle contributes to a decrease in its output. An increased load on a right ventricle, pronounced bronchospasm, is formed, which leads to decrease in ventilation of the lung and increase in blood shunting. Stagnation in the venous of the systemic circulation is quickly formed. Acute right ventricular overload often causes ventricular fibrillation and death. The clinical picture is acute right ventricular failure reflects the symptoms of stagnation of systemic circulation. How the patient quickly develops sudden shortness of breath, cyanosis, pronounced swelling of the veins of the neck with increase in inspiration, palpitations, cold sweats, heart pain, pulse small and frequent, fallen blood pressure. Later, pathological pulsation in the epigastrium appears, a rapid increase in the size of the livers, and intense pain of right hypochondrium due to straining of the liver capsule. Even later, parsley and swelling of the legs. Next, primary cardiogenic heart failure. Formed as a result of primary decrease in the contractile function of the heart with close to normal volume of venous blood flow, occurs when ischemic heart diseases, myocarditis, cardiomyopathy. Secondary non-cardiogenic heart failure formed as a result of primary predominant decrease in venous flow to the heart with close to normal volume to contractile function of the myocardium. Observed when acute massive blood loss, violation of diastolic relaxation of heart and filling its chambers with blood when the heart of compressed with fluid accumulating in peripheral pericardial cavity. Prolonged episodes of paroxysmal tachycardia, vasodilation, collapse. Compensation mechanism for heart failure. Mechanism of compensation of hemodynamic in heart failure. Urgent compensation mechanism. It is cardiac mechanism, extracardiac mechanism, long-term compensation mechanism, myocardial hypertrophy. Urgent compensation mechanism, cardiac mechanism, is an increase in strength of heart contraction, tachycardia. Increase the strength of heart contraction. Let's talk about urgent compensation mechanism, in particular about increasing the force of heart contraction. An increase in the strength of heart contraction occurs according to Law's mechanism. The first is a Frank-starling Law's mechanism, and second, Laplace mechanism. Frank-starling is Law's status. The more the heart muscles is stretched by the incoming blood, the greater the force of contraction, and the more blood enters the arterial system. In other words, the stroke volume of the heart increased in response to an increased volume of blood in the ventricles before contraction, when all other factors remain constant. As more blood flow into the ventricle, the blood stretches the fibers of heart muscles, which increase the force of contraction. The Frank-starling mechanism allows the synchronization of cardiac output with venous return arterial blood supply in normal lengths, regardless of external regulation to make changes. The physiological significance of mechanism lies mainly in maintains equality in emissions of left or right ventricles. From the Frank-starling laws, the following particular practical conclusion can be drawn, which is used in treatment with heart failure. Diuretics must be used. This is done in order to reduce the preload, since when taking diuretic and volume circulation blood decrease. The Laplace mechanism says an increase in the contractility of the heart with an increase in resistance load on it with a constant length cardiomyocytes, or the other words, an increase the force of heart contraction is directly proportional of the tangent force of the cardiomyocytes. Next slide, urgent compensation mechanism, extracardiac mechanism, neurohumoral. So the mechanism of emergency compensation of additional cardiac mechanisms, extracardiac mechanisms act. They contribute to occurrence of tachycardia and increase the minute blood volume. BANEBRIDGE reflex, BETSOLD-YARISH reflex, pairing reflex. The BANEBRIDGE reflex is a reflex increase in the frequency and strength of heart contraction in response to an increase in pressure in the vena cava in the atria. That is an increase in central venous pressure. First describes by BANEBRIDGE, FA. Later it was found that with a weak stimulation of the strengthening receptors of the heart, the frequency and the strength of heart contraction increase, and with stronger stimulation they decrease. It has now been shown that the direction of heart reaction is determined by interaction of intracardial and extracardial nervous regulation mechanism. The BETSOLD-YARISH reflex. It was first described in 1867 by German physiologist Albert von BETSOLD and German therapist and occupational pathologist Ludwig Girt. It is reflex expansion of arterioles of systemic circulation in response to irritation of mechano and chemoreceptors localized in the ventriculus and atria. Is a result systemic atrial hypotension occurs, which is accompanied by bradycardia and temporary respiratory arrest, apnea, followed by hyperpnea. The reflex is triggered by decrease in nervous return to the heart. Afferent and efferent fibers of the vagus nerve are involved in this inflammation. This reflex is aimed and unloaded in the left ventricle. It can cause, for example, reflex painful collapse in the first 60 minutes with myocardial infarction, etc. The clinical significance reflex is that above described triad can develop with local anesthesia, complication of interscalene brachial reflux, blockade, spinal condition, anesthesia. Next point, bleeding, compression of inferior vena cava. Everything says about the mechanism of compensation of cardiac activity equally applies to both left and right ventricular failure. The expression to parent reflex to action of which realize only when the right ventricle overload with is absorbed pulmonary embolism. Parent reflex, a reflex increase in blood filling of the spleen, bradycardia and hypotension in response to irritation of the baroreceptors of the pulmonary trunk, serves as on lines of systemics that provide reflex coordination of the vascular tone of the small of large circulation. In addition, the parent reflex characterized by appearance of shortness breath associated with the onset of brain hypoxia. It is believed that the parent reflex realized by increasing of tonic effects of nervus vagus of the cardiovascular system and pulmonary embolism. Implement only with right ventricular overload absorbed with pulmonary embolism. Next slide, long-term compensation mechanism, this adaptation mechanism. Long-term intracardiac mechanism are a progressive process of myocardial remodeling dependent on the triggers factors and presented in the form of compensatory hyperfunction of the heart, which is based on myocardial hypertrophy, long-term extracardial mechanism of compensation in heart failure, compensatory hyperactivation of neurohumoral systems aimed at increasing the work of heart, sympathoadrenal system, myocardial renin-angiotensin system, and renin-angiotensin-aldosterone system. Compensatory hyperactivation of redundant oxygen transport system, erythropoiesis, and external respiration. Manifestation of this group of mechanism, secondary erythropoiesis with increased blood viscosity and increased load of heart dyspnea. Myocardial remodeling, it is a restriction of the existing structure and progressive dysfunction of myocardium in response to prolonged damage, overload, or loss of part of the functioning myocardium. Options for restrictions: the myocardial structure, myocardial hypertrophy, change in the geometry of the ventriculus, dilation of heart cavities, myocardial fibrosis. Long-term intracardiac compensation mechanism with prolonged stress of the heart, for example with valvular defect, primary arterial hypertension, compensatory hyperfunction of the heart develops. Compensatory hyperfunction, the following stage develop emergency, completed hypertrophy and relatively stable hyperfunction, gradual exhaustion of progressive cardiosclerosis. The emergency stage develops immediately after an increase in the load of the heart and is characterized by a combination of pathological and compensatory adequate change in the myocardium with the mobilization of myocardial reserves in the body as a whole. The emergency stage of characterized by pronounced pathological changes in the myocardium. Manifestation of acute heart failure is a combination with mobilization of the reserves of the heart muscles and the body as a whole. On average, is last a week and end with increase in myocardial mass by 30 and 17% due to increase in proteins synthesis. Reduced stroke volume. Cardiac output decreases, blood pressure decreases, the load per unit of muscles mass increases, the intensity of functioning of structures increases. This is the average daily numbers of functions performed by unit mass of cellular structures. The intensity of oxygen consumption by myocardium decreases. Accumulation of oxidized metabolic products. The activity of ITP resistances decreases. The activity of ITP and IDP resynthesis increases. Glycogen and creatinine phosphatase decrease. The intensity of glycolysis increases. Lactate increases. The content of natrium and calcium of myocyte increase and content of myocyte decreases. 2. Activation of genetic apparatus of cells increases. The synthesis of RNA, proteins, and nucleic acids increases. 0 is hypertrophy of mitochondria and increases their numbers. 0 is increases the mass of functioning structures, myofibrils. The activity of ITP or resistances increases. The mass of myocytes and numbers of organelles of them increases. There is hypertrophy and hyperplasia of the nervous and vascular structures of the myocardium. The stage of completed hypertrophy and relatively stable hyperfunctioning. At this stage, the process of hypertrophy is complete. The mass of the myocardium is increased and no longer grows. The mass of myocytes increases by 1.5 3 times. The critical mass of hypertrophied heart is 500 grams. Intensity of functioning of structures is close to normal. Oxygen consumption, energy generation, and macrophages content don't differ from normal values. Synthesis and utilization of ITP correspond to normal values. The activity of calcium-activated ITP phase increased. The content of natrium and potassium of the myocyte returns to the initial values. Normal levels of activity of the genetic apparatus. Hemodynamic parameters were normalized. The hypertrophied heart has adapted to new load condition and can compensate them for a long time. The following feature is of hypertrophied myocardium. And dysregulation of hypertrophied heart due to the growth in nerves ending from the increase in mass of cardiomyocytes. Decrease in the vascular supply in the myocardium as a result of lack of growth of arterioles of capillaries from the increase in the size of mass of muscle cells. The development of relative coronary insufficiency, an increase in mass per unit surface area of myocardial cells, considering that transport enzymes are localized at the sacrolemma, substance of metabolism, receptors, proteins. 0 is change caused by development of ionic imbalance, metabolic disorders, cardiomyocytes, and regulation of their function. Decrease in level of energy supply of myocardial cells due to lag and increase in mass of myocardia comparison with the mass of myofibrils. Violation of plastic process in cardiomyocytes as a result of relative decrease in numbers of mitochondria and decrease in area surface of cells, volume of myovasculature, and the difficulty of energy and substance necessary for the biosynthesis of structures. Decrease in the contractile function of the heart. The stage of gradual exhaustion of progressive cardiosclerosis is characterized by profound disturbance of metabolism and structure of the myocardium. The develops of the wear complex of hypertrophied heart. The development of large amount of connective tissue in the myocardium, loss of elasticity for myofibrils, deterioration of regulation condition heart, leading to violation of contractile properties of heart muscles. The main reason for the development of the wear complex is leading behind the growth of mitochondria from the growth myofibrils during the development of hypertrophy. Part of the myocardium becomes energetically unsupported as a result of which the contractile elements die and replaced by connective tissue, and the functioning muscles fibers change a number of their physiochemical properties, and they cannot to carry out the process of transformation of ATP energy into actomyosin energy. Progressive exhaustion compensatory resource of the heart leads to heart failure and later circulatory failure. Characterized by significant structural, metabolic, and functional disorders, gradually emerging and increasing the energy generating and contractile elements of myocytes, and with a dose of parts of cardiomyocytes, proliferation of connective tissue, impaired relaxation of contraction of muscle cells of heart, and the formation of chronic heart failure. Next slide, long-term extracardiac compensation mechanism. As I said, long-term extracardiac compensation mechanism is heart failure. It is a compensatory hyperactivation of neurohumoral system aimed at increasing the work of the heart, sympathoadrenal system, myocardial renin-angiotensin system, then the renin-angiotensin-aldosterone system, and compensatory hyperactivation and redundant oxygen transport system, erythropoiesis, and external respiration. There are positive and negative effects of compensatory hyperactivation of neurohumoral system. Positive effects: partial temporary compensation of the minute volume of blood and systemic hemodynamic, minimalization of hypoxia, hypoxic organ dysfunction, improvement of the quality of life. The main mechanism of sympathoadrenal stimulation are as follows: activation of sympathetic nerves, cause of positive inotropic effect, increased frequently spontaneous depolarization, pacemaker membranes, facilitated impulse condition of Purkinje fibers, increase the frequency and the force of contraction of typical cardiomyocytes. The actions of catecholamines of carried out through B100 energetic receptors through the G proteins, adenylate of cyclase is activated with formation of cyclic adenosine monophosphate. Cyclic adenosine monophosphate dependent proteins kinase unactivated. Phosphorylated protein P27 of sarcolemma, In the sarcoplasm of entry of calcium increase through open voltage gates, calcium 2 channels, mobilization of calcium into the cytosol enhanced through activate renodine receptors, calcium binding the tropin C and removes the inhibitory effects tropomyosin of the interaction of actin with myosin. Calcium removes the inhibitory effects tropomyosin of the interaction of action with myosin. A large number actomyosin bound are formed and the force and contractions increases. However, with the progression of the process, these mechanisms are depleted since they require an increased supply of oxygen and substrates to the weakened myocardium. The structures of weakened cardiomyocytes cannot provide an adequate response to pronounced stimulation, are depleted even more in cardiotoxic effects, so the myocardium is formed. Next slide, long-term extracardiac compensation mechanism, negative effects. Negative effects, cardiotoxicity of excess catecholamines and components of renin-angiotensin aldosterone system, the participation of neurohumoral system of myocardial remodeling and progression of systolic and diastolic dysfunction, hemodynamic of myocardial overload. It is a systemic vasoconstriction with myocardial pressure overload, water retention in the body with myocardial volume overload. An excess of catecholamines of myocardium causes the following negative effects: dysfunction and death of cardiomyocytes, necrosis and apoptosis, vasoconstriction of peripheral vessels with increased overload, resistance load, prolonged tachycardia, vasoconstriction of the coronary vessels, increased myocardiac oxygen, demand with worsening ischemia and myocardial hypoxia, provocation of arrhythmic myocardial hypertrophy with progressive diastolic dysfunction, activation of the myocardial renin-angiotensin system and renin-angiotensin-aldosterone system. Prolonged tachycardia is particularly important since the first is a compensatory adaptive reaction, but later it contributes to an even greater depletion of myocardium, which means it goes into prolongical reaction. This is main pathogenic tachycardia assessment. An excess of angiotensin II in the myocardium cause direct stimulation effect cardiomyocytes occurs positive inotropic effect, which leads to overload of hypoxia with dysfunction or death of cardiomyocytes, strengthening of adrenergic insufficiency of myocardium, spasm of coronary vessels with ischemia as a result, impression of proto-oncogenic of cardiomyocytes fibroblasts leading to hypertrophy, diastolic dysfunction with myocardial fibrosis. Hyperactivation of sympathoadrenal system, myocardial renin-angiotensin system and renin-angiotensin-aldosterone system is chronic heart failure contributes to early remodeling and myocardial dysfunction, total vasoconstriction with decreased organ perfusion in fabrics, sodium and water retention increased, blood circulation, increase the pre and afterload, further decrease in contractility and pumping function of the myocardium, progression of the chronic heart failure. Common feature in intracardiac hemodynamic and heart failure are an increase in the residual diastolic blood volume due to incomplete systole, an increase in the diastolic pressure in the ventricles due to increase in the residual systolic blood volume, dilatation of the heart, change in the minute blood volume, decrease, but there may be increase. With left ventricular failure, increased pressure in the left atrium, pulmonary circulation, and right ventricle, there may be pulmonary edema. With right ventricular failure, increased pressure in the venous of systemic circulation of right atrium. Okay, I spoke briefly about heart failure. Thank you for attention. See you.